I have the honor to introduce Professor Monika. She will talk on the dilemma of gray zone lymphoma management in pediatric age group.
This is a challenging topic to discuss because there really isn't much data at all. So I am doing my best, I hope, and to talk about the gray zone lymphomas in pediatrics. And what it really is represented by this picture. It's neither fish nor bird. It's somewhere in between, or maybe both at the same time. And there was this study, Dr. Garbone tried to show how the evolution of Hodgkin lymphoma classification and where does the gray zone lymphoma fall. So let me see if I can find a mouse here. So here are your Hodgkin lymphomas. You have the nodular lymphocyte predominant Hodgkin lymphoma, the lymphocyte-rich Hodgkin lymphoma, which in a way there is some overlap or sometimes some confusion more than an overlap between these two types of lymphomas. Then we have the typical nodular sclerosing Hodgkin lymphoma and mixed cellularity or the lymphocyte-depleted Hodgkin lymphoma. So when we're talking about the gray zone lymphoma, or particularly the mediastinal gray zone lymphoma, it is often an overlap between the classical NS Hodgkin lymphoma and a primary mediastinal diffuse large B-cell lymphoma. But then there is also this group up here, which is the nodular lymphocyte predominant Hodgkin lymphoma, which today some investigators feel shouldn't even be called a Hodgkin lymphoma and actually should fall under the non-Hodgkin lymphomas, which has a continuum towards a T-cell-rich, histiocyte-rich B-cell lymphoma. So those are the caveats here that we're talking about. And let's see. So I will concentrate most of my talk on the gray zones between the Hodgkin lymphoma and the primary mediastinal large B-cell lymphoma. And I'm talking about a patient that I saw several years ago. It was a 9-year-old with a 1-month history of intermittent left-sided chest pain. A workup at his local emergency room showed that he had leukocytosis with normal differential and some anemia. And a PET CT of the chest showed peritracheal lymph node enlargement and diffuse mediastinal involvement and splenic lesions. He had no B symptoms. So this was his PET scan at presentation, and it is not unusual compared to what I would normally see. He's got here supraclavicular on both sides, mediastinum, and the spleen is involved. He was staged as a stage 3A, intermediate risk, and so I treated him according to the Euronet C1 with OIPA COPDAC. He got 2 cycles of OIPA, 4 cycles of COPDAC, and then he went on with radiation. After I finished radiation, I did his end of therapy scans, and to my surprise, he had all this disease. To my surprise, because after 2 cycles, he actually was in remission, pretty much everywhere. So this was completely unexpected. And here's where I want to just underline again, while everybody would say, well, clearly he relapsed and this is lymphoma, so don't waste your time and just do whatever you would do for a relapsed Hodgkin lymphoma. I never ever treat a relapse without a biopsy confirmation. Never ever. And this is what his biopsy showed. It shows mainly a diffuse large B-cell lymphoma pattern. And when the pathologist went back to look at his original diagnosis, he could tell that there were some characteristics in some of the places where the Hodgkin lymphoma sort of had some characteristics of diffuse large B-cell lymphoma. But here at this 4 months after he finished therapy, this is more of a diffuse large B-cell pattern. And in this publication, talking about what it is that we look at when we're reviewing the Hodgkin lymphomas and the gray zone lymphomas, is we're looking particularly on the histological architecture. So we have neoplastic, it should be a B, not a P, sorry. Neoplastic cells that resemble Hodgkin-Ridge-Thornberg cells. They are CD20 positive, they are CD30 negative, they're often CD15 negative, CD30 positive, CD15 negative, PAX5 positive, and OCT2 positive. So gray zone lymphomas, they can either show up with both characteristics, as I said, and then you would have like this type of pattern where you don't see, you see Hodgkin and non-Hodgkin at the same time when you look under the microscope. But sometimes they can appear concomitantly without being so intermixed, then it would be more like a composite. So you have big patches that are Hodgkin and big patches that are diffuse large B-cell lymphoma. Or in some cases, they can succeed or supersede, come afterwards. So you have a Hodgkin lymphoma initially that then on a relapse comes as a diffuse large B-cell lymphoma, which is probably what my patient had. So the German group decided to look at the clinical, pathological, and genetic features of primary mediastinal large B-cell lymphomas and gray zone lymphomas in children. And they saying that this is a continuum between both. They looked at all the primary mediastinal B-cell lymphomas that had been entered into their trials and did a retrospective review to see how many of them were actually mediastinal gray zone lymphomas. And they found 52 cases from European pediatric lymphoma studies, so it wasn't just the Germans, it was also the Italians. And they found, 52, and there were 7 pathologists that looked at these lymphomas and had to categorize them as either primary mediastinal B-cell lymphoma, mediastinal gray zone lymphoma, classical Hodgkin lymphoma, diffuse large B-cell lymphoma, or Burkitt's lymphoma. And and these could be either synchronous or composite lymphoma. So the synchronous is where you have the big patches together, and the synchronous is where they're intermixed, and the composite is where you have the big patches together. So, and so these were just the characteristics on how they classified them. So what they found is they found a total of 44 cases were confirmed primary mediastinal B-cell lymphoma, and 4 cases were mediastinal gray zone lymphoma. So this is so rare. Lymphomas comprise less than 20% of all your tumors in childhood. Only 4% are primary mediastinal B-cell lymphomas, and of these, only 8% are mediastinal gray zone lymphomas. So we're talking about really very, very few patients ever and at any time. So 4 cases were mediastinal gray zone lymphomas, and then there were 2 cases of diffuse large B-cell lymphomas. And in two cases, it wasn't possible to classify. And this is when they compared them, they had the same characteristics, whether you are a primary mediastinal B-cell lymphoma or a mediastinal gray zone lymphoma. Do you express exactly the same? The only difference was in the expression of BCL2, and this is a patient with a marginal zone lymphoma with a synchronous part where it looks more like a primary mediastinal B-cell lymphoma, and another part that looks more like a Hodgkin lymphoma, and this is characteristic. They also did some genetic studies, but out of the 4, they couldn't even do it in 4, so I'm not even showing you here the results because I don't think that you can make much out of that. So then, Dr. Burkhardt from the non-Hodgkin lymphoma group, together with Dr. Maus-Kerholz from the Hodgkin lymphoma group, decided to take together all their cases from the Hodgkin lymphoma and the non-Hodgkin lymphoma trials and see how they did. And they found a total of 23 patients with gray zone lymphomas that were diagnosed between October of 2004 and September of 2013. And in all but one case, the diagnosis was confirmed by one of the reference pathologists. So this group consisted of 9 gray zone lymphomas that were between classical Hodgkin and diffuse large B-cell, 3 gray zone lymphomas that were between classical Hodgkin and primary mediastinal large B-cell lymphoma, and 10 gray zone lymphomas that were between the lymphocyte predominant Hodgkin lymphoma and the T-cell rich B-cell lymphoma. So they had a total of, these are your, and then one that was NLP, so nodular lymphocyte predominant Hodgkin lymphoma versus diffuse large B-cell lymphoma. And 15 of these patients had received treatment according to Hodgkin lymphoma protocols, and 8 patients according to the NHL protocols, including one that got escalated Apoc. And 14 patients relapsed, so that's a pretty significant number of patients with this pathology relapsed. So 7 patients that had this combination between Hodgkin and diffuse large B-cell relapsed, and 2 that had the combination of Hodgkin with primary mediastinal, and 5 that had somewhere between the LP Hodgkin and the T-cell rich B-cell. And it didn't really matter whether they were treated according to the Hodgkin or the non-Hodgkin lymphoma protocols. And a total of 6 out of 11 patients with gray zone lymphoma that were between NLP and T-cell rich stayed in remission after frontline treatment. So the only ones really that had a chance of not relapse or just were the LP, because only 3 of the 12 patients that had any classical Hodgkin-related gray zone lymphoma stayed in remission. So definitely having a gray zone lymphoma that involved aspects of Hodgkin lymphoma appears to be bad prognosis. It still doesn't tell you how to treat them, right? Because they were treated according to whomever they fell into their hands first. So in conclusion, the identification and implementation of the optimal treatment strategy for these gray zone lymphomas requires cooperative initiatives, according to Dr. Maus-Kerholz and Dr. Burkhardt, but they didn't come up with a solution. This was only an abstract that was presented, and they haven't published it as a paper yet. So then I found another case series of pediatric patients treated for gray zone lymphoma, and they had a much more optimistic outview. This was published in the Pakistani Medical Association journal. They found 4 cases, ages 13, 15, and 7 years of age, who had stage 2, or 2 had stage 2 and 2 had stage 3 disease. None had a mediastinal mass, so it was probably not the classical Hodgkin versus primary mediastinal. And all patients were treated according to NHL guidelines, so they were treated like non-Hodgkin lymphomas. Apparently, they're all well, and they all tolerated chemotherapy, and so they felt that this was a good, not a bad prognosis in any case, but it's only 4 cases, and it is very difficult to accumulate many of these cases. So on this paper, on whether is it better to have a composite lymphoma, meaning that it arrives, you have it synchronous at the same time, or a sequential lymphoma. And this paper looks at 25 cases with gray zone lymphomas. So this is a retrospective review of composite and sequential lymphomas in adults that were between classical Hodgkin and large B-cell lymphoma that were treated between 2000 and 2018. The composite or synchronous lymphomas were defined as the association of classical Hodgkin lymphoma and large B-cell lymphoma, be it primary mediastinal or just diffuse large B-cell. And these are samples simultaneous on the same sample or on 2 different sites, but at the same time. So if somebody got two biopsies, it was fine as long as both characteristics were there, or on the same biopsy. And the sequential was defined as the occurrence of classical Hodgkin lymphoma followed by large B-cell lymphoma, or the other way around. So either one or the other. Treatments were classified as either diffuse large B-cell-like, like they received either CHOP, ACVBP, or Copatum, or Hodgkin-like, and they were treated with ABVD and Viacom, and that was obviously according to what their primary presentation suggested. And the treatment response was assessed according to the revised and current lymphoma criteria of Chesson. So they were all classified with PET scan. So this is a composite lymphoma. This is an example where you can see in this one single cut a whole piece that is very diffuse large B-cell-like looking, and the rest being very much Hodgkin lymphoma. And again, so this is just on H&E. Here on CD20, you see the diffuse large B-cell patch and the Hodgkin lymphoma patch, and the same as here for the CD30. As you would expect, your diffuse large B-cell is CD30 negative, whereas your Hodgkin is CD30 positive. And here again on the stains. And on the patients that they found 10 patients that had composite lymphomas. And the blue bar shows the time that they were getting treatment. The green dot is that they are in CR. This is the follow-up time. And at the end, your star is that they are alive and in remission. And as you can see, they are all alive and in remission. 2 patients relapsed or were refractory initially, actually, and require an autologous stem cell transplant, these 2 patients, but they are still alive and in remission. So these are the composite or synchronous lymphomas. They found sequential lymphomas also, and this is the example of a patient who at diagnosis had a Hodgkin lymphoma, classical Hodgkin lymphoma, CD20. This one happened to be CD20 positive, but in any case, CD30 positive too, and then at relapse had more of a primary mediastinal diffuse large B-cell pattern with more blastic appearance of the cells. And as you can see, these patients did not do well at all. So particularly those that had a very early relapse, I don't know if you want to call it relapse or happening of the second lymphoma, they all succumbed, or most of them did actually. Here, there are only 3 that are alive from these patients, and they got aggressive therapy, including allogeneic transplant, the solid red dot, or autologous stem cell transplant with this donut-looking circle. Only the ones that had a late appearance of their second lymphoma, and they didn't characterize what late is. I suppose that it's after a year, but it wasn't clearly defined. These patients fared better, and all of them are alive, but some after another relapse. So going back to my patient, this is how he looked like at the time, 4 months after treatment. And what I did for this patient is reinduce him with LMB type therapy. And even after significant chemotherapy, he was not getting into remission. It was very hard. In July, we finally decided to take him to transplant, and he still had some avidity, but very little. So today I would call it negative, but this was 6 years ago, so it was a W3, and we called it positive. So we had a discussion: should he go to allo transplant or should he go to auto transplant? And we had seen the literature that autologous is not better than allogeneic transplant, but it was very hard to get him into remission. And so, despite the fact that I am definitely an advocate for autologous stem cell transplant for Burkitt lymphomas, I have to admit we took him for an allo transplant because we just felt that we were not going to be able to cure him. And today he is alive and in remission, 6 years. So, but what about those patients that have LP Hodgkin lymphomas versus T-cell rich B-cell lymphoma? Because those are a challenge as well. And it is something that seems to be having like a revival. I hear more cases about this. It seems like the pathologists are more in tune to look at these changes. And there's this landmark paper by Fan where the different architectures are described. So you can see that pattern A would be a B-cell-rich nodular pattern, so that's just a typical LP Hodgkin lymphoma. But then you start having some changes. Pattern B is serpiginous, interconnected. Then pattern C is prominent so you see that your prominent extranodular LNH cells. Here you have them outside. Then this is a T-cell-rich nodular. And then here you have pattern E, a diffuse T-cell-rich B-cell or almost diffuse large B-cell lymphoma type. And here a diffuse moth-eaten B-cell-rich. Again, so we at St.Jude, we do not classify them like this. I wish we did, and we may start doing it. I know that the Europeans, the Pediatric European group is very much looking into this because the UK has found that these variant patterns do show put them at higher risk for relapse, but it's something that is still ongoing and under review. And then I got this patient a few years ago, a 15-year-old, who presented with a several months history of an axillary masses on the left, no fevers, night sweats, or weight loss. And the biopsy revealed that she had LP Hodgkin lymphoma. And as one is, even though I'm more careful today than I used to be, I told the parents, oh, I'm not too concerned. I mean, she probably has a stage 2. I don't expect any surprises with the PET scan. And if I'm telling you this, it's probably because there was a surprise. So she came to St.Jude, and I did a PET scan. And this is a patient with LP Hodgkin lymphoma. I had never in my life seen this before. And she was totally asymptomatic. She had no complaints at all. As a matter of fact, she was trying to ignore it because it was just burdensome. 15-year-old, you want to go on with life at school. And so how to treat a 15-year-old with stage 4 LP Hodgkin lymphoma? Again, this was several years ago now, in the meantime, maybe 5 years ago. At that time, I decided to go with 2 cycles of OIPA. Today, maybe I would go with 2 cycles of R-OIPA. And then she got Copdac, so I didn't just treat her with 2 cycles. But I want to show you the PET scan after 2 cycles of OIPA. After 2 cycles of OIPA, I did not expect this at all. So this patient finished her therapy and did not get radiation. But the question lingered in my mind, is this truly LP Hodgkin, or was this a more aggressive non-Hodgkin lymphoma? But we reviewed the pathology, and it was definitely LP Hodgkin lymphoma. In the adult literature, patients that have splenic disease are treated a priori as non-Hodgkin lymphomas. We don't do that in pediatrics yet. It may change, but I had no indication to treat her as a non-Hodgkin lymphoma patient, so she got 2 OIPAs and 4 Copdacs. I can tell you that for the last 3 years now, I have been following her for enlarged lymph nodes under her arm. So she's got recurrent axillary nodes. When you look at her PET scan, very concerning for relapse. So I've biopsied it, and it just shows follicular hyperplasia. This just again to underline how important it is to do biopsies, because if I would have just gone by her scans, I would have already transplanted her some time ago. And I have done 2 biopsies, and I have to sit on my hands to not keep biopsying her. But particularly these patients with LP Hodgkin lymphoma that may have a transformation, or not a transformation, be it sort of like these gray zone lymphomas, they tend to have other lymph nodes. I had a football player also with axillary disease who I had been following after his treatment. He had this recurrent axillary node that was very firm, very significant, and I'm like, I am worried, but at the same time, I don't want to overreact. Tell me when it's good for you, for us to do a biopsy, just so that you can forget about it. And so come in the summertime, we'll take it out, and I did a biopsy, and it was follicular hyperplasia. But they look on PET scan. The PET scan doesn't know the difference between follicular hyperplasia and Hodgkin lymphoma. So very important to be aware of that. So in conclusion, gray zone lymphomas represent a lymphoma with characteristics of classical Hodgkin lymphoma and B-cell lymphoma, most often primary mediastinal. They can be composite or appear sequentially, so either synchronous or sequentially. The sequential lymphomas appear to be more aggressive, and there is no defined standard treatment approach. So I wish I could tell you how to treat them. I still don't know how to treat them. I can tell you that those where the pathologist tells us this is an LP Hodgkin lymphoma, but it looks like a T-cell rich B-cell lymphoma, I have treated like non-Hodgkin lymphoma. But in my patient with a generalized disease, that was not the case. The pathologist didn't say that. And all lymphomas suspected of relapse require biopsy confirmation to confirm histology, because you do not know if your Hodgkin is now a non-Hodgkin or if your original non-Hodgkin had turned into a Hodgkin and requires different treatment. So again, with an invitation to the symposium in Germany, thank you very much.
Any question?
Yeah. Well, Professor Monika, I would like to thank you so much for the effort that you did. It's such a hard topic and pretty much confusing. It really stand out for everyone who's hearing this. But let me talk about the gray zone lymphoma. So the gray zone lymphoma, you are discussing the topic, which is the expression of many typical features which you can see with the different subtypes of lymphoma. I don't know about the pediatrics, but let me tell you about the adults. So the gray zone lymphoma in the adult age group differed so much in the few years before, because they have a special designation now in the WHO. They put it under the high-grade B-cell lymphoma with the intermediate features between Hodgkin's disease and diffuse large B-cell, or between diffuse large B-cell and Burkitt's lymphoma. And in both, we have the same results as regards the outcomes when they are using now more of intensive chemotherapy, as all of the medical oncologists do. So we just try to intensify chemotherapy. Well, I do think that there was very interesting paper Dr. Lewis Stout published a year ago in the New England Journal of Medicine, in which he started to see about the genetic makeup for the diffuse large B-cell lymphoma, and found out that there is around 100 recurrent mutations, and is trying now to subtype them so that we will be able to differentiate more not on the immunohistochemical features that we see on the cell or the patterns that we see, but more into the biology of the disease that we are facing, so that it will, I know it's very difficult now to be reproducible, especially in community oncologists, but I do believe that this will be the way, not just intensifying the treatment, but mainly intensifying the treatment with more smart way and trying to target the BCL2 or trying to target the EZH2. Now we have it on market. So actually they're trying to use, or using the mid-A inhibition. So they're trying more into opening up targets and refraining away, let me say, refraining away from the immunohistochemical features, more into the genetic makeup, so that they would, at the end of the day, try to solve the dilemma of the gray zone lymphoma. And especially in others, because we see it like more common than in pediatrics. So you're talking about 4%, no, we see more in the adult age group, and we see a lot of composite lymphoma. And we usually see, I have been seeing that, but usually because we used to do a lot of biopsies and a lot of full workup for our patient, is that you pick up two types of lymphoma in the same patient. So at the end of the day, I really thank you, and I do believe that the pediatric age group, so for once, like you have been leading the train for the lymphoma treatment, even for the adults, for a while now, but they are thinking more in the adult way, more into the genetic makeup, and this is the way that you should go into, as I do believe. And thank you so much for the beautiful presentation.
Thank you. No, thank you. I appreciate what you're saying, and I agree with you. When I do see a patient with non-Hodgkin lymphoma characteristics in a Hodgkin lymphoma patient, today I treat like a non-Hodgkin lymphoma. So treating like an aggressive lymphoma makes much more sense, and definitely the way to go.
Thank you. My question is about, is there any plan to classify the gray zone, whether it's a specific subtype or a subtype from, or mid-zone between the Hodgkin and non-Hodgkin by the next generation sequencing?
I did not find that, but I'm sure they're looking into that, and maybe it is in Dr. Stout's paper that I did not look at. So.
Thank you for your nice presentation. I really enjoyed. My first question was asked by my colleague Haru about. I was a little bit confused about unclassified lymphoma and the gray zone lymphoma. But my second question: is there any relation between EBV infection and the gray zone lymphoma or unclassified lymphoma in your experience? EBV infection.
So in one of these papers, actually. I believe gray zone lymphomas are not so often EBV positive, but I cannot tell you for sure. I don't know if the colleague from before, can you comment on that? Is EBV more often in gray zone lymphomas in adults?
So the Epstein-Barr virus has been found to be to promote for the translocation in chromosome 9. And this is not the case. We usually see it in the primary mediastinal B-cell lymphoma or in the Hodgkin's disease. So these are the things that we see more of the Epstein-Barr virus infection, and they are related to the Epstein-Barr virus. And this actually leads to the expression of PD-L1, and it explains why the PD-L1 are being used now more in Hodgkin's disease and primary mediastinal. But with the gray zone lymphoma, there is no data that I know of.
Thank you.
Hello. Thanks also for this nice presentation, very elaborative. I'm just asking about the role of usually in Hodgkin lymphoma after transplant to do irradiate those patients. We have a patient with composite lymphoma of a Hodgkin and diffuse large B cell. I'm just asking, is there a rule to deal with it like Hodgkin and to do irradiate them post-transplant? Thanks a lot.
On the papers that I found, it really is depending whether you're following a classical Hodgkin lymphoma approach or you're following the NHL approach. So in pediatrics, NHLs are not irradiated, only Hodgkin lymphomas. However, adults do irradiate primary mediastinal diffuse large B-cell lymphomas sometimes. So I guess it depends on which approach you're following. Are you treating like a Hodgkin lymphoma or like a non-Hodgkin lymphoma?
We're treating it like a Hodgkin lymphoma.
So if you're treating like a Hodgkin lymphoma, and if your recipe sort of calls for radiation, if there is no adequate response after early, then I would probably irradiate.
Just one more question, one small one. We know that Hodgkin and primary mediastinal B-cell lymphoma have 100% expression of PD-L1.
Yes.
So what about the gray zone lymphoma? Does it express the PD-L1 as well?
So that's what the colleague was mentioning before. I'm not sure that it does. Can you comment on that, please?
I'm sorry, I didn't get the question.
Whether the gray zone lymphomas express PD-L1?
So there hasn't been an association between the PD-L1 and the gray zone lymphoma. The gray zone lymphoma is usually, it's gray. The problem is that it expresses the features. So the term is actually done based on immunohistochemical features. So you find out that cases that you have diffuse large B cell case and it's expressing CD30, just like the Hodgkin. So, and you find diffuse large B-cell cases with very high proliferative index, with Ki-67 almost 90%, which is basically just like the Burkitt's lymphoma. So, and you will find the starry sky appearance, and it has the full immunohistochemical makeup of a diffuse large B-cell. So these are the gray zone lymphomas. We actually don't know what's the problem that expresses this basically on the cellular surface. So this is why we're trying to solve this problem of the cytological feature into more genetic makeup. So when we looked up in the genetic makeup, or they're trying, not me of course, they're trying to look up in the genetic makeup so that we would be able to find, and this is the beautiful paper, I would love to share it with you, about Dr. Lewis Stout. He has been working on this, and the subtyping of the diffuse large B-cell lymphoma, mainly since the 2000, and he's the guy who created the term of the double hit and the double expressor. So when he started out, he started to find the recurrent mutations, and then he genotyped, or he did the next generation sequencing for a lot of patients. I can't remember the number, and he found out that these patients, they have 100 recurrent mutations. And then he tried to subtype them according to the targetable mutation, the driver mutation that can be targeted subsequently so that it would be treated or reflected into our practice in the end. But having the problem with the PD-L1 is that the PD-L1 in the diffuse large B-cell lymphoma expression is very low, basically. It is just prominent in the Hodgkin and in the primary mediastinal B-cell, and this is due to the presence of the chromosome, the amplification of the chromosome 9p23. So this is basically the PD-L1 expression part, but for the diffuse, and this is why the diffuse large B-cell lymphoma did not respond to checkpoint inhibitors when they tried to use it. They don't have the receptors for the PD-L1. So this is why it has failed, like the Nivo, the Pembro, all of them have failed in the diffuse large B-cell. But the problem is that when you talk about the gray zone lymphoma is not a diffuse large B-cell, it's not a Hodgkin's disease, it's some way between the both, it's somehow between both, or between the high grade or the Burkitt's lymphoma, the subtypes. These are the subtypes that we have seen in the adults.
Thank you.
Thank you, Professor Monika.